Thank you. I thank the organizers, Dr. Sudeep sir and Dr. Shonana, to allowing me and inviting me here. So I'll be rapidly reviewing 7 abstracts in the ER positive subset. So starting with the first study, this is the trial, phase 3 randomized trial, which looked at the addition of oral ibandronate with adjuvant endocrine therapy in postmenopausal women. The question that they tried to address was whether adding oral bisphosphonate improves survival in this cohort. Earlier studies and EBCTC meta-analysis had showed that probably in the postmenopausal group, adjuvant bisphosphonate might increase survival. So this was a randomized multi-center phase 3 open-label study where postmenopausal women with the stage of 1 to 3 and PR positive patients were randomized 1:1 to endocrine therapy alone, and the intervention arm where ibandronate was given for 3 years. The primary endpoint was 3-year DFS. After more than 1,000 patients who were randomized between Feb 2007 to May 2014, there was no difference seen in the DFS. The 3-year DFS rates were 94 versus 91, and at 7 years it was 79% in both the arms. These were the DFS curves. So the authors concluded that adjuvant ibandronate 50 mg daily does not improve DFS and should not be recommended. My take on this is that 18% of the patients in the ibandronate arm stopped the therapy early, and more than 1/3 of this early stoppage was due to the GI side effects. The optimal bisphosphonate dose, schedule and duration is still unresolved, and this was the first randomized phase 3 study looking at this postmenopausal group, and these drugs probably at the best delay rather than prevent the bone mets, because the benefit that was seen in the early 3 years was lost during the later follow-up. Coming to the second study, this was another phase 3 randomized study looking at the addition of everolimus to adjuvant endocrine therapy in patients with high-risk hormone receptor positive HER2 negative primary breast cancer. We all know that that everolimus in the metastatic setting has improved PFS when added to exemestane in the BOLERO-2 study and then added to tamoxifen. So the investigators tried to address the question whether everolimus added to endocrine therapy in the high-risk hormone receptor subset would improve the survival. So this was a phase 3 randomized study which looked at a high-risk subset group, more than 4 nodes positive, and if the patient had received neoadjuvant therapy, at least 1 node should have been positive. And in the group of patients with 1 to 3 nodes, they did a endopredict clinical score, which was, if higher than 3.3, the patient was included. Everolimus was given for 2 years along with adjuvant endocrine therapy, and the primary endpoint was DFS. After 1,200 patients that were randomized between June 2013 to March 2020, there was no difference seen in the DFS with a hazard ratio of 0.95. The 36-month DFS was 88% in everolimus arm versus 89%. Grade 3 or more higher adverse events were much higher in the everolimus group, 30% versus 16%, the most common being mucositis, transaminitis, hypertriglyceridemia. These are the DFS curves. We can see that there is no difference. So authors concluded that everolimus does not improve DFS in the high-risk hormone receptor positive subset and should not be recommended. Everolimus is a drug which is not easy to tolerate. More than 1/3 to 1/2 of the patients in the study required dose modification, and more than 1/2 of the patients had to stop the therapy. There was also a death in the everolimus arm due to septicemia and mucositis, and that is a possibility that we should all consider. And hence, alternative safer treatment strategies, probably CDK4/6 inhibitors, are required in this subset. Coming to the third, this was a safety and a patient-reported outcomes of the monarchy study, which looked at the addition of abemaciclib to endocrine therapy for 2 years. This was a detailed safety analysis and PROs of the patients who were enrolled in this study. So we all know that this was a randomized multi-center phase 3 study which looked at the node-positive high-risk group of patients, where patients were randomized to endocrine therapy alone versus endocrine therapy with abemaciclib given for 2 years. The safety population included all those patients who had received at least 1 dose of the drug, and more than 5,500 patients were analyzed in this study. At the cutoff, more than 90% of the patients had completed the abemaciclib treatment, 72% because of the treatment completion of 2 years, and 17.4% patients because they had discontinued the treatment prematurely. The median compliance to abemaciclib was good, more than 98%. Grade 3 and higher adverse events were much more higher in the abemaciclib arm, 49.7% versus 16.3%. When we look at the grade 3 and higher adverse events, we can see that diarrhea 7.8% in the abemaciclib arm versus 0.2% in the endocrine therapy arm. Neutropenia, which was more of a lab abnormality, 19.6 versus 0.8. Infections, 5.6 versus 3. Fatigue and transaminitis again higher in the abemaciclib arm. Two side effects of concern, venous thromboembolism and interstitial lung disease of any grade was also seen higher in the abemaciclib arm. The diarrhea, which was the most troublesome side effect leading to dose modifications and early stoppage, was generally low grade. Grade 2 to 3 events were highest in the first month and subsequently decreased. Most of the side effects were short-lived and did not reoccur. Venous thromboembolisms were higher with abemaciclib with an increased VT risk, which was observed more with the tamoxifen as the endocrine therapy partner as compared to aromatase inhibitors, 4.3 versus 1.8. The PROs were also similar between both the arms except for diarrhea. At more than 3 months, most of the patients reported diarrhea as a little bit or somewhat concerning to these patients. So the authors concluded that abemaciclib plus adjuvant endocrine therapy has acceptable safety profile and tolerability, and which is also supported by the patient-reported outcomes. Most of these adverse events were reversible and manageable. My take on this, that this is a mature data with more than 90% of the patients having completed the planned treatment with abemaciclib. Over 25% of the patients discontinued abemaciclib, and this was mostly due to diarrhea and fatigue. More than 40% of the patients required dose modification. If we looked at the patients who had stopped abemaciclib early, more than 50% of those did so without any dose modification. So although side effects like diarrhea is a concern, but they are manageable, and hence they should be treated as early as possible with those modifications and supportive measures, and also patient counseling for symptom management is important, especially in this group. VT is another concerning side effect that one should watch out for. Now, coming to the historical reanalysis of 3 big studies by the International Breast Cancer Study Group, where adjuvant endocrine therapy of AI was compared with tamoxifen. Here, the investigators tried to see in the selected subgroup of patients with a higher risk of cancer recurrence, what happened during the initial 2 to 3 years when AI was compared with tamoxifen. So this was the analysis of 3 studies by the IBC SG group, that is Big 198 soft and the text study. With more than 8 years of median follow-up. The analysis cohort was HER2-negative cancers with a clinically high risk, and the clinical high risk was similar to that of the inclusion criteria of the monarchy study. The endpoint was the disease-free survival. If we look at the study population, the high-risk population in each of this study trial was in the range of 14 to 26%. That is only a very significantly lower proportion of patients came into the high-risk group. And in the below graphs, we can see that the hazard ratios with AI versus tamoxifen was in the range of 0.7 to 0.8, and there was an early treatment effect seen at 2 years, which was maintained at 5 years. So the authors concluded that treatment effects emerged by 2 years and were indicative of those that would maintain over the next 5 years. The relative and absolute benefits that were seen with AI at 2 years were similar in magnitude to that seen in the monarchy study with the addition of abemaciclib to endocrine therapy. The early benefits are possibly greater. So my take on this study is that these are promising results. However, a very small number of patients from each of the study had a clinically high risk with a significant variability around the estimates. Also, the number of patients who had received neoadjuvant chemotherapy was underrepresented in these trials. So the IDFS events and patterns varies over time, and the patients must be followed up even beyond the 2 years to actually gauge the beneficial effect of endocrine therapy. Now coming to the a novel study where the investigators tried to define the minimal effective dose of exemestane. This was a randomized pre-surgical trial of alternative dosing of exemestane in postmenopausal women. So the patients were randomized, operable breast cancer patients in the postmenopausal patients were randomized to receive 3 different dosing patterns of exemestane. The exemestane 25 milligram per day, 25 milligram 3 times per week, and exemestane 25 milligram once a week, with the primary endpoint of % change in the circulating estradiol levels. The results was that there was no significant difference between once daily arm and the thrice in week arm. As we can see that the percentage of participants with the estradiol suppression was similar in the once daily and the thrice weekly arm. whereas it was much lesser in the once a week arm. A similar % change in the estradiol estrone levels was also seen in the once daily and the thrice in a week arm. The secondary endpoint of Ki-67 reduction and progesterone receptor reduction was seen in all the arms, and also there was a much better lipid profile in the thrice a week arm of exemestane. So the authors concluded that exemestane thrice a week showed similar benefits compared to once daily dosing, and there was no difference in the Ki-67 or progesterone receptor decrease. The results look promising, but the treatment duration is short. It can possibly be used in intolerant women. Now coming to the study which looked at the addition of aspirin, adjuvant aspirin in breast cancer patients. This was a randomized phase 3 study where patients were randomized to receive endocrine therapy plus placebo versus endocrine therapy plus aspirin for 5 years. The primary endpoint was IDFS, and at the pre-planned interim analysis, for futility, the trial was closed because there was no difference in the IDFS. In fact, the hazard ratio was more than 1. And greater than the pre-specified hazard ratio of 1.03 for futility. There was no difference in the grade 3 or 4 adverse events, and compliance was high and similar in both the arms. So to conclude, there is no benefit of adding aspirin, and this is a time to give up evaluating aspirin, at least in the breast cancer patients. Coming to the last study, where it was a retrospective population-based cohort study to estimate the association of tamoxifen with endometrial pathologies. And this was done in the Korean National Health Insurance database. The patients receiving tamoxifen versus those not receiving tamoxifen had a higher incidence of endometrial polyps, hyperplasia, and endometrial cancer, as we can see in this graph. So premenopausal women have a higher risk of endometrial hyperplasia, polyps, and uterine cancer with the use of tamoxifen. And these results are in contrasting to that of the EPCTCG and other Western studies, where it showed that probably tamoxifen increases the risk of endometrial cancer in postmenopausal women. So there is an definite increased risk as seen in this study, and we need to do further studies and additional monitoring in the future. Thank you.